Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I'm your host, Dr. Kyle Concannon. Today, we'll be talking about colon cancer and what is colon cancer. And with us today are JJ Singleton and Dr. Mark Lewis, who I'll let introduce themselves. We'll start with JJ. Maybe you could tell us a little bit about yourself.
Yes, it's an honor to be here. As you said, my name is JJ Singleton. I'm from a very small town outside of Asheville, North Carolina. I was diagnosed with colorectal cancer in September of 2015 and have been going on through chemo and surgeries and everything ever since. So this year will be a decade since being diagnosed. But again, it's just an honor to be here.
It's great to have you. And thanks for taking the time here. You've been in the cancer field for longer than I have. So you have quite a lot to teach us. And then we also have here Dr. Mark Lewis.
Yeah, thank you so much for having me, both of you. So my name's Mark. I'm an oncologist. I'm also a patient with cancer, and my cancer developed in a hereditary fashion. So I inherited a genetic mutation from my father and my father before him. So I had a slightly rare form of pancreas cancer myself back in 2017. But in my professional life, I treat cancers of the gut, like what has affected JJ. And so, JJ, it's really an honor to talk to a patient like yourself, and hopefully together we can educate our audience here.
So the first question I wanted to have kick us off here, and keeping in mind the patient who may be newly diagnosed with colon cancer, someone with a colon polyp, is just having the understanding of this organ that became cancerous, the colon. What is its function? What does it do? And then what are the things that cause cancers to form there? And Mark, maybe you can kick us off here.
Yeah, absolutely, Kyle. So one of the things I wanted to say to your audience is there's actually no need to overcomplicate this. I have a surgeon friend who describes himself as a plumber. And what he means by that is the gut is just one long tube. And I am going to, use some terms here that might, make your audience blush a little bit. So it goes from mouth to anus. And the main purpose of the colon is actually to absorb water, sort of reclaim water from what we eat and drink before the stool is defecated. So one of the things to point out, especially if someone is contemplating surgery, is you can survive without some or even all of your colon. Obviously, that'll change your quality of life. But really, the colon has less to do with nutrition than you might think, and a lot more to do with, again, reclaiming fluid so we don't get dehydrated. The other thing that's really interesting to me, at least, is the colon is technically, in my mind, two different organs that are fused together. So this goes all the way back to when we're babies. In fact, before we're babies, when we're embryos. So when we are in utero, literally when we're in our mother's womb, the colon forms by two separate parts of the gut getting connected, what we call the midgut and the hindgut. And the reason that's relevant, as we might get into later, is the right colon and the left colon down into the rectum are arguably different organs. And that matters, especially in the more advanced stages of colon cancer. So that's just one thing to think about. So I started by simplifying it as a tube. On a genetic level, again, it's actually arguably two different pieces of tubing that were kind of fused together kind of in the middle. And then to your other point about, well, why does anybody get colon cancer? I'm going to zoom out for a minute and actually ask the question, well, why does anybody get any cancer of any kind? And as an oncologist, one of the most heartbreaking questions I get asked by patients, especially in our first visit, is, Doc, why me? And the honest answer is, I don't always know. Sometimes I have a suspicion, but sometimes we just have to guess. And I hate to say it, but sometimes it falls into the category of bad luck. Putting it slightly more scientifically, there's a absolutely brilliant oncologist and author, Dr. Siddhartha Mukherjee, who has written several wonderful books. I think he's written actually the best book ever about cancer called The Emperor of All Maladies. But in his sequel to that, which was called The Gene, he too broadened his focus. And in that book, he proposes a formula, which I'm going to share with your audience now. And he says the formula for cancer is our genetics, literally what we inherit from our parents, plus our environment, plus triggers, and we'll talk about what those might be with the colon. And then finally, he talks about chance. And again, that might be summed up as bad luck. So let's talk about environment and triggers. The other thing that's really important about the colon is how many bacteria live in the colon. We're recording this in 2025, and frankly, we still don't quite understand the relationship between our health as humans and all these bacteria that live in our gut. And sometimes that population of bacteria is described as our microbiome, sort of this whole other universe of bacteria that populate the inside of our bodies, and especially in our colon. And again, if you look at the colon as right-sided versus left-sided, the bacteria actually look very, very different on the right side than they do on the left. And the reason this is relevant is there is a strong suspicion that antibiotics that we might take, especially in childhood or as teenagers for infections, if we take antibiotics then, it can meaningfully change the bacteria that line the gut. And over years and maybe even decades, the bad bacteria, if you will, can overcome the good bacteria, and maybe those bad bacteria can lead to forms of colon cancer. So that's one, I think, very compelling theory as to why we're seeing more colon cancer, especially in young people. So that's one aspect of it. One of the things I get asked about a lot in terms of triggers is diet. And again, I want to think about just how long the gut is as a tube. So at the top of the tube, once you swallow your food, it goes down your esophagus and enters your stomach. And your stomach is literally filled with a bath of acid. And it's incredibly acidic. And then once the food leaves that, it passes your pancreas. And the pancreas itself basically sort of squirts out these very, very caustic enzymes that help you break down the fat and the protein that are in your food. And my point in saying all of this is by the time your food gets down to your colon, which is the last stop before you poop, it has been thoroughly digested, and it has gone through basically this sort of, if you will, crucible of the upper gut, where there's all these digestive juices that are allowing us to break down our food and get nutrition from it. My point being, there are very few foods, and specifically there are very few toxins that can sort of survive that gauntlet to cause cancer in the colon. The only risk I tell my patients about in terms of food is charred meat. So again, I know JJ is coming to us from the Carolinas, Kyle, you're in Texas. These are both famous sort of barbecue regions in the United States. I love barbecue myself. But the truth of the matter is really the char, the sort of carbonization of the outside of meat, that may be the one thing I can think of that can survive all the acid and the enzymes of the upper gut and actually cause potentially a carcinogenic effect on the lining of the colon. So these are things that we can potentially modify. We can't change our genes necessarily, but we can be very thoughtful as doctors, at least, about how we prescribe antibiotics. And my wife's a pediatrician, and she thinks a lot about, does she actually need to give an antibiotic to a child or a teenager? We can be, moderate in terms of our barbecue consumption. And again, I know that's hard depending on where you live.
We could be.
The final thing that you actually already mentioned in the intro is this whole notion of polyps. So one of the things that makes the colon so interesting to me also is you can almost see some of the colon cancers coming as they develop on the lining of the colon. And you also mentioned, I think in the intro, this procedure called colonoscopy. So the way I think about it is, imagine you're looking down the tube of the colon. It should really look like a perfect cylinder, like it should be perfectly circular, and it should be smooth. The lining of the colon actually looks a lot like the inside of our cheek. It's kind of pink and glistening. But what you don't want to see on it are bumps. And so the most common form of polyp is basically like a finger-like growth that sort of protrudes or juts out of that smooth cylindrical lining and is now inside the colon. And so the food and the stool are passing by that polyp. And as a general rule, polyps can range from completely benign, meaning they'll never become cancer, to sort of intermediate risk, where if the polyp is left to its own devices over the course of years or maybe even a decade, it'll become cancer. And then finally, there are these really worrisome or aggressive polyps that if you leave that polyp in there in a matter of a year or so, it will become so invasive that it'll become a cancer itself. So why do polyps matter? Well, if you have a colonoscopy, what that means is a doctor is inserting a tube with a camera up your bottom, so up your anus, and going through the rectum and the colon. And if they see polyps, then by and large, they will remove those polyps. So why does that matter? So my sort of mantra is colonoscopy might be one of the only cancer screening tests, so looking for cancer, that can also prevent cancer. And the best analogy or comparison I can think of is, listen, we're all men, but women's health is frankly way ahead of men's health in terms of cancer screening. Most women start getting mammograms around age 40. And when a woman goes from a mammogram, what she's doing is compressing her breast tissue, basically in an x-ray plate, to see if there are problems. But the mammogram just detects problems, it doesn't remove them. On the other hand, whether a woman or a man goes and gets a colonoscopy, if a colonoscopy sees a polyp and that polyp is removed, you have now also taken away the risk of that polyp becoming a cancer. So all of this is really sort of an advertisement, if you will, for the power of colonoscopy. I think it's an incredibly useful, not just screening tool, but arguably cancer prevention tool. The reason most people don't go and get colonoscopies, though, is, to say the least, the inconvenience. I'm 45. I had my first colonoscopy this year, so now I know what I'm talking about. I've been through it myself. You have to prep for a colonoscopy, which means you have to cleanse your entire colon. And so, at least in my case, what that involved was drinking, several gallons, if you will, of a very unpleasant Gatorade-like solution that basically had me in the bathroom all night. And in the morning, there was literally nothing left in my colon at all. I lost 3 pounds, which tells you how much came out. And then in the morning, a gastroenterologist, a special gut specialist, put a camera up my bottom, looked at my whole colon, and I had 5 polyps, all of which were removed and thankfully were benign. So that's the reason that more people don't go and get colonoscopy. And the final thing I'll say, I know this is a very long answer, is colonoscopy has 2 different types, or what we call indications. There's a screening colonoscopy, which means that at a certain age is appropriate for you to go through this procedure to see essentially if you have any polyps. And the reason I did mine at 45 is I am at average risk for colon cancer. And these days, we recommend that an average risk person, man or woman, get their first colonoscopy or their first screening at 45. So that's why I did it. I'm no different than anyone else. I did it just like I'd recommend for any of my patients. The important distinction here, though, is there's also something called diagnostic colonoscopy. And what I want your audience to hear is, if you're having problems like abdominal pain, unexplained weight loss, and specifically blood in the stool, you should bring those things to the attention of your doctor, and that may well get you a colonoscopy younger than 45. If you're having those problems, there is no need to wait for this arbitrary 45-year-old threshold. You can get a colonoscopy in a diagnostic fashion to figure out why those things are happening to you. So again, what's special about the colon? It's a long tube. You can have some or all of it cut out and you can survive. But these polyps are really sort of the origin for most colon cancer. And the good news for your audience is that if we find polyps early enough, we can remove them and we can prevent many people from getting colon cancer. Colon cancer is not entirely preventable, as I'm sure JJ can tell us himself. But we have a powerful, powerful tool here in colonoscopy that can intervene in a way that other cancer screening cannot.
Yeah, what a great explanation there. Thanks for being so detailed. And
Of course.
I imagine hopefully for some of the folks listening who may be listening because they have a concern, hopefully this provides not only some insight, but maybe a little bit of reassurance for some of those folks. And we'll get into later some expectations and, what some of the next steps might be if you're not in this category of identifying a locally advanced colon cancer or a polyp or something. So we'll talk a little more about that in a moment. JJ, are you comfortable speaking to what that initial diagnosis was like for you? Is that what happened? You had a colonoscopy and it identified a colon cancer? Or
Yeah,
what
I'm
happened?
totally comfortable. Mine was a little bit more complicated as I was 27 and I was a typical man who was like had pain. I was like, I'm okay. I was in the middle of training for a CrossFit competition, so I was like, I pulled a muscle, got an ulcer. That's why this. And unfortunately, I was single. I didn't have no kids, so at 27, I was like, I don't really want money coming out my paycheck to go to health insurance at the time. So I ignored symptoms. I had blood in my stool. I had a throbbing pain, and I just kept ignoring it until my amazing mom made me go to the doctor. And by that time, you could literally see a tumor like throb through my skin and my abdomen. And within 2 days, I was getting a colonoscopy, and then I was in surgery. But yeah, The only thing I'd ever heard about a colonoscopy was the things I seen on like a Saturday Night Live sketch or, a sitcom. And it completely like opened a whole new world to me.
Was your experience, preparing for the colonoscopy, getting it, was it as bad or?
It wasn't as bad as anything that I'd seen on TV. It wasn't great because I did the prep on Labor Day when I was supposed to be watching my favorite college football team play, and at the time I lived with a younger brother and a best friend, and they weren't not gonna cook out on Labor Day and have fun. So I was drinking preps while they were eating hamburgers and doing that. So, but I will say the best part of the whole colonoscopy, other than getting answers, you do get a really good nap. Probably the best like 30-minute nap I get every year.
From the sedation?
Yeah. So
Yeah,
that's usually like when people are asking me, I'm like, the prep's not fun. You will feel clean out later, and just enjoy the nap.
yeah, I've never seen it pitched as an insomnia treatment, but or, for those who don't get good sleep at night, like try colonoscopy. It could be ask your doctor if colonoscopy is right for you. Um, well, yeah, thanks for going through your experience and your diagnosis and some of the symptoms you were having. Um, I want to get to, we have this tube, which is the colon, and inside it is you've described, Mark, that lining is like the inside lining of the cheek, and that's made up of cells like every other organ in your body is made up of. What's happening to those cells that turned them into colon cancer, and what's unique there?
Yeah, absolutely, Kyle. So, and JJ, great explanation. And you're right. They typically give you a medicine called propofol for colonoscopy, and you do get an absolutely fantastic nap from that. So, kind of a fringe benefit of colonoscopy. I'm glad you advertised that. Back to Kyle's question. So, Kyle, you're right. So, the colon, like any other tissue in the body, is composed of cells, as you mentioned. And one of the things that's absolutely mind-boggling to me is just how efficient our cells are at containing genetic material. So almost every cell of our body contains DNA, and that DNA is 3 billion, with a B, billion letters long. And one of the things that's truly remarkable is, thankfully, when mistakes are made in those 3 billion letters being copied to make a new cell, thankfully, most of those mistakes are completely meaningless and absolutely do not give us cancer. On the other hand, those mistakes, which we also call mutations, can absolutely add up over time into cancer, and they can certainly cause the polyps that we mentioned earlier. So one of the things, again, that's so interesting about the colon is, if you think about it, this is actually almost as much physics as biology. There's a tremendous amount of friction that can happen, especially if we're underhydrated, if we're prone to constipation. There's a tremendous amount of friction that can happen as food becomes stool and it passes through the colon. And so my point is, these letters, these mutations that occur, we used to think that they built up in a very specific sequence to give rise to polyps, and then those polyps would again degenerate into cancer. And it turns out that, I've been in this business for about 20 years now. Turns out that it doesn't have to go in this exact sequence that we thought it did. But for your audience to know, over time, especially once polyps have developed, as those polyps in turn develop their own mutations, that's how we think they break down and become cancer. And the reason that genetic risk, meaning inherited risk, matters is some of us are literally born already having a mutation that will then predispose us. It kind of almost, unfortunately, kind of sets us ahead in the sequence. And so we'll get in, of course, to JJ's story, but even in my own case, the reason I developed this weird form of pancreas cancer is I was born with a mutation already. And there's something called the two-hit hypothesis, which means that if you're born with one mutation, you're basically just kind of waiting as you go through life for that second mutation to happen. And it's typically that second mutation that gives you cancer. So all of this is to say, it doesn't matter to your audience. It really shouldn't, exactly which mutations we're talking about here. But just the act of being alive, of nourishing ourselves and having food pass through the colon, unfortunately gives rise to friction and inflammation that can cause mutations. And once again, most colon cancer arises from polyps, which are already in their own sense mutated. And then finally, the polyp gets enough mutations that itself becomes cancer. And then I'm sure we'll talk here about staging in just a minute.
Mark, thanks for that excellent explanation there. The next thing I'd love to jump into, you mentioned colonoscopies can identify small colon cancers that can be removed right there. But JJ, you had mentioned your cancer was larger, that wasn't able to be done. So I was wondering if you could go through the different stages. What do those stages mean? They're different for every tumor type. And in general, brushstrokes, what does that mean for colon cancer?
Yeah, certainly I can start, and then I know we'll talk about JJ's experience, which sounds deeply personal, and I imagine it at the beginning, JJ, really scary as well. So staging is an important way for an oncologist to tell you what is the extent of a cancer in your body. And so we have staging systems for literally every type of cancer. I actually find the colon cancer staging fairly intuitive and relatively easy to explain. So again, let's go back to that cylinder, looking down sort of the tube of the colon. If your cancer is confined to that inner smooth lining that we talked about, then that's a stage 1 cancer. And as you mentioned, Kyle, that's the easiest to remove, typically with surgery. However, the other thing to remember is not only do you have that smooth inner lining of the colon, but somewhat remarkably, the entire colon is ringed by muscle. And JJ talked about sort of working out and preparing for like a triathlon. This type of muscle is not skeletal muscle. It's not the type of muscle that we build up by exercise. This muscle, thankfully, is there and it's involuntary. And it's a good thing it is, because that means that when we all swallow food, we don't have to sit there and think, okay, now I'm moving the food from my stomach to my small intestine and from my small intestine to your colon. The body just does this automatically, and it's absolutely amazing that it does. However, that muscle that contracts to propel the food through your gut, if the cancer grows from the inside lining of the colon into that muscular layer, which again completely encircles the colon, now you've got a stage 2 colon cancer. Again, that can be repaired and cured with surgery alone. Where things start to get a little bit more intimidating, and where oncologists like myself tend to get involved, is the next stage, which is called stage 3 colon cancer. So now we've gone beyond the smooth inner lining, and we've gone beyond the muscular layer, and now we're into basically these little filters that surround the colon called lymph nodes. And again, you have hundreds of lymph nodes in your body. Pretty famously, when women have breast cancer, we sometimes need to remove lymph nodes underneath the armpit on the side of the affected breast. And that can leave the women actually with swollen arms, because those lymph nodes are also important for draining fluid out of the arm. This is a lot different. These lymph nodes around the colon, they just serve the colon, so you can safely remove them and you won't have any problems later on with swelling. However, those lymph nodes are a structural part of your immune system. And the reason they're there is to filter anything abnormal coming out of your colon. And it's great that they're there. If they can catch cancer cells that are trying to get from your colon to other organs, like, say, the liver, then they hold on to those cells. And when we remove the lymph nodes at the time of surgery, we can actually see those lymph nodes containing colon cancer cells. But if you have a single lymph node removed at the time of surgery that contains colon cancer cells, now you have stage 3 colon cancer. And you will almost certainly end up meeting, after surgery, an oncologist like me to talk about whether or not you might need chemotherapy. And we'll talk about why that is. And then finally, there's stage 4 colon cancer. And it sounds like JJ has a pretty harrowing story to tell us, but stage 4 means that the cancer cells have gone beyond the lymph nodes and they've gotten into a distant organ. And all of the blood flow, all of it, from the colon goes to the liver to be purified. So unfortunately, in my clinic, most of my patients are dealing with cancer that has gone beyond the inner layer, the muscular layer, and even those lymph nodes, and now it's in an organ like the liver. And that, absolutely, we need to talk about chemotherapy. Because the way it gets there is actually traveling beyond the lymph nodes through the blood, through the bloodstream, to the liver. So what the cancer cells are doing, which is so sneaky, is they're using the natural blood flow, where again, blood will normally go from our colon to the liver. And that's actually great that it does that, because what it's doing is purifying the things that we eat and drink. So for instance, alcohol. When we drink alcohol, it famously actually gets metabolized in our liver. So the blood flow from the gut normally goes to the liver as part of our normal physiology. But unfortunately, the cancer cells use that same pathway, and that's how colon cancer tends to end up in the liver. As a very brief aside, the rectum, which we mentioned at the very top, has a different blood flow. And so cancer cells from the rectum can actually bypass the liver altogether, and they can end up in the lungs. So again, we have to think about the colon as having two sides, and the rectum is arguably even a different organ altogether than the left colon. So the reason oncologists like myself get involved is if you're dealing with a stage 3 colon cancer and certainly a stage 4, almost always patients will be offered chemotherapy that we put deliberately into the bloodstream to kill cancer cells that are moving through the circulation from the colon to these distant organs. And we won't get into the weeds of stage 3 colon cancer here today, Kyle, but I will say that sometimes when we remove the cancer and we find a lymph node, we'll actually offer the patient chemotherapy to eliminate any microscopic cells that might remain, because unfortunately, any cell left behind after surgery is a cell that can grow over time and cause more problems. And that's what we call adjuvant chemotherapy. One way of thinking about it is like an insurance policy. You've had the surgery, we saw the cancer in the lymph node, now we're giving you chemo to prevent the cancer from ever growing back. But if it's stage 4 and it's in a distant organ, that's a much bigger problem that I'm sure we'll talk about. And chemotherapy is almost always offered there. There are some opportunities to manipulate the patient's immune system that we'll also discuss later. But yeah, that's when a medical oncologist like myself, a quote unquote chemo doctor, might get involved in a patient's case, even beyond or after surgery.
And when you say stage 3 can get chemo, stage 4 can get chemo, one question I've heard a lot is for how long?
Right.
What should they expect?
So this may not sound short to your audience, but for a stage 3 colon cancer patient, it may be as short as 3 months, maybe as long as 6 months. Stage 4 patients are different. Stage 4, you basically treat until you don't see the cancer anymore. Unfortunately, in cases that we can't cure, it's almost like the cancer becomes a chronic illness, and that person might be on chemotherapy or some form of treatment for the rest of their life. And I'll just show my bias. My clinic, I almost never see stage 1 colon cancer in my clinic because they don't need to meet me. Stage 2 cases are a little bit nuanced, and we don't have time to divvy those up. But stage 3 colon cancer patients in my practice, I'll probably treat those patients for between 3 and 6 months with chemotherapy. And stage 4 patients are likely to remain with me for the entire rest of their lives. Every now and then, I have to say, we have such incredible success treating stage 4 colon cancer that after 5 years, they might not need me anymore. But the vast majority of my practice, and it's just what we call selection bias, it's based on the cases that are referred to me. Most of my patients with stage 4 disease will stay with me for the remainder of their lives.
Okay, yeah, that's great to know. And for people who are going through a diagnosis themselves and wondering, what kind of conversation might you soon be having with your care team, I think this lays a really good foundation. And JJ, you were someone who was diagnosed with stage 4, right? And maybe you can tell me what was the diagnosis experience like to you? Because one thing that I think is interesting is we as providers, we talk a lot about the expectations that we're involved with, but I like to say for someone who's trying to understand something new, you can talk to the mechanic and the person who designed the car, which is very much Mark and I. But you really want to know what that's going to be like. You want to talk to the person who's driven the car. And I look at you and I'm like, you're the expert of having colon cancer. And you're actually probably the person that is going to give people the information they are most likely going to need and use and leverage in their own life. So I'm really eager to hear, what was the experience like being diagnosed? We'll start with that, and I want to go a little bit into your experience with treatments too. But we can start with diagnosis.
Yeah, no problem. Actually, at the first, when I was first diagnosed, I was actually diagnosed with stage 2. Like, my tumor was a very huge tumor, and it had grown outside of the colon, where they had to remove like 80% of my colon and 36 inches of my small intestines. But the lymph nodes came back clear. But it was very quickly. Like, I still did, the frontline FOLFOX chemo because I was young, and they were just like, we really want you to, like you were saying, kill any microscopic cells since they cut so much. But then 6 weeks after I was done with that chemo, I felt the throbbing again, and my cancer had, spread to my abdominal wall and lymph nodes throughout my body. So that's kind of like, but there's I hate to say it, a lot of similarities of getting a diagnosis of just cancer, like stage 2 or whatever, and then coming back and getting, re-diagnosis stage 4. It's always going to hit you, like,
Yeah.
I think it's like it takes the wind out of you, but then at the same time, the wind never comes back to you. So it's like getting the wind knocked out, but you're constantly trying to breathe. And then you just learn about the onslaught of information from doctors, from surgeons, from everywhere and everybody. And I probably talked to more people when I first got diagnosed, but also at the same time, I felt more alone than I ever have in my life because I didn't know anything about cancer other than, again, like a colonoscopy, what I'd seen on TV. I had a very, blessed family. Like my great great grandpa, he died of cancer. And then a lot of people, we just, live in that backwoods area where if they didn't go to the doctor, we didn't know why they died. It was just, God's will. And, you pray and then you move on. But specifically to the stage 4, like when I got re-diagnosed, and that's when they were, you're incurable, the treatments in your abdominal wall, your lymph nodes, it's resistant to these certain types of chemo. It's just like I was, automatically thinking, well, I'm not never going to see my 30th birthday. And just I associate it automatically with death. And at that time, it wasn't as, I didn't know where to go for information or where to go for help or to connect with people. It is a little easier over the years now, with the social media and everything. But the biggest thing, like when I got diagnosed, was just the isolation and the alone feeling, and then just not knowing what to do or where to go. And it was like I felt fully, at the use of my medical team, which luckily I loved mine and I had full faith in my oncologist and the medical team, but I couldn't imagine the people that don't have that to still go through there. So that's really kind of how my diagnosis was a little bit different because I went through the stages, but very similar to just the overwhelmingness of it.
Yeah, and you've mentioned something I've heard from, some other folks too, and I think when we talk about what's the most difficult thing about initially being diagnosed, hearing the social isolation and the lack of, an ability to do much. You're helpless. You don't, there's nothing. It feels like it's totally out of your hands. And over time, what were some things that helped you, fix the social isolation part, and then give you a sense of autonomy and uh, control?
Yeah. Over time, I think it changes, and everybody's going to be different because we all are, our all lives are made up of memories and experiences that are different. But for me, it was finally coming to the realization that I couldn't do it by myself. I couldn't handle the physical burden of surgeries, of chemo, the mental burden of, yeah, I have cancer and I'm always going to have cancer. And then just the emotional thing of living in such a small town. I'm like, that's what everybody thinks of me as soon as they see me now. I'm the guy with cancer there. So a therapist, and then like really understanding that even though, again, I grew up at a place where we didn't really talk about mental health. You didn't really discuss it as a guy. You're supposed to be able to shoulder it. To know that it didn't make me weak, that I needed help. I needed to talk about it, to go to therapy. And then once I started doing that, that allowed me to be able to open up online and find people I could connect with that had not the same, but similar experiences to where I wasn't alone. I didn't feel like I'm the only one in the world that is feeling these feelings or going through this. And like, again, like I said, we talked to so many people, even at times in advocacy groups, in your doctor, in your chemo, like infusion centers. But at the same time, you still felt isolated because, you are different and individual, and like they don't go home and have to do the same experiences that I do. So just, I'd say accepting that and then realizing that I could talk about it and get help. And then where's that, like the mental part that allowed me to focus more on the physical part and realize that I could, get hydrated. And just through 9 years, you learn little tricks that helps me with my body. Like I don't eat for 2 days. I do meal replacement shakes before treatment because it's easier to throw up liquid than it is food. Some people don't like that and they like, to like feel full going in there. And I'm like, that more power to you. But for me, and just learning little tricks that help you as an individual can change that whole next 3 or 4 days where you are going through hell.
And when you're talking about um, going online, are these patient advocacy groups, or what are the things that you reach out to get these tips from people who have been through it before?
Yeah, that's been a very crazy journey for me too. Because when I started, I didn't like the patient advocacy things because I was like, I'll just let 4 hours of a doctor and infusion. I don't want to just go to these places and just have people ask me detailed medical questions or talk about that. And I finally found one that was more of just it's a group for men with cancer, and it's just so we don't isolate. And then you can go in once you feel comfortable and have those conversations. And everybody in there has went through a cancer or some sort of cancer, so you can be very like vague. But like if I'm vague in a question to somebody, even an oncologist, you don't get it because you haven't had to wake up in the middle of the night with the chemo or do everything. So it's like you don't have to be as detailed in there, and that's what helped me. And then from there it led on to other advocacy groups, and I've made some of the best friends in my life that I couldn't imagine life without through there. And really it's just a lot of with the isolation, because if you isolate, that can affect your mental and your physical outcomes.
Yeah, that was really well phrased. Thanks for sharing that. And you were mentioning navigating the symptoms of chemotherapy and that you had been through many surgeries. Could you speak to what the experience of going through chemo was like for you?
Yeah, chemo was it rocked my world. Because again, the only thing I knew about chemo was what I'd seen. I was like, well, I'm going to lose my hair and I'm going to get really skinny, and everybody's going to know I'm sick. Well, with the first chemo I had, and I was getting steroids, I kept my hair and I gained 30 pounds. And I was like, well, they were like, oh, you must not be on the bad type of chemo. I'm like, well, I just spent 3 days laying in the bathroom floor throwing up. But, so it was just like going off of what you expect or what I expected it, because the only few things I knew, and I didn't have anybody to really ask that had been through, because nobody I knew had ever went through colon cancer. And I quickly realized like the women I knew that went through breast cancer and colon cancer chemos, very, very different side effects. They didn't have to deal with the cold sensitivity from Folfots, or where I couldn't drink anything cold for 5 days. And I got so sick of warm Gatorade and warm water that, it's like, it's a whole different kind of world there. So it's really just, again, as bad as it sounds going through chemo, learning a process that you can deal with it. Like, you go through those educational things before chemo, and the doctors will be like, well, you should try this and this and that. And some of them might work, others of them might not work for you. And just realizing that you can change your path to make your quality of life as good as it can be. And once I realized that, I won't say I'm good at getting chemo. I just know that I can get through it each time, instead of like absolutely dreading it and think I'm going to die every time I get an infusion.
Yeah, it sounds like it started off pretty rough.
Yeah, it was very, very like, and I started in November, and it was a really cold winter, and I didn't know what to do with cold sensitivity. And I was I've always been a person, like, through all my chemo, I get very nauseous, and I didn't know how to, like, the right way to take all the different nausea medicines, or what to eat, or how to do this. And then mouth sores, like learning that mouth sores could be more than a fever blister that can just impact everything in daily life. And so it's just, new things that might not happen to a lot of people that you've known with chemo, that they're happening to me. So it's, you learn a lot living through it.
Over time, did those symptoms get more manageable, or you found the tricks that you're mentioning?
I think some of them got more manageable, and then especially through the years, is like I'm not on like the hardcore full thoughts or full theory anymore. I'm more on a immunotherapy and a combination of another drug, which they still have side effects. Like I still deal with some really big like skin issues. Like if you see me walking around at certain times, especially during the winter, it almost looks like I'm over here like having a reaction because I'm itching the dry spots in my skin. But the biggest thing is going through it. I learned how to make my life as manageable as I can. Like you learn to deal with the fatigue in a different way. Like whatever works for you. Like I'm the person where I can take a nap or I can stay up and I'm still exhausted, but it's like I can keep going until I sit down that day, and then I'm just done. Before I was like, well, they told me I need a nap. They told me I need to rest here, so I would do that. And it just learning that everything isn't as black and white as what they'll give you on the paper. It's more of like a suggestion, then you learn to what fits you the best. It's kind of like all the advice that I ever give about chemo, and that's what has made me able to stay on it so long and still enjoy parts of life.
Yeah, thanks for sharing that. And similarly, you've gone through surgeries too. Now, when I think of a surgery targeting the colon or, for colon cancer, I imagine anyone who's facing that is probably feeling really anxious. What was your experience like going through that surgery?
I realized really quick that I hated hospitals because before that I never spent the night in the hospital. The only surgery I had was when I broke a finger playing basketball and get my like adenoids taken out. So I realized that the hospital gets very very quiet and very lonely at night. But a lot of it was just scared, like fear and scared because I it was an unknown. Nobody I had known had like had their stomach opened up and intestines cut out, and they were like, oh yeah, your intestines will be paralyzed, and we don't really know how long because everybody's different. And then we're going to start you back on broth. You can't drink nothing for so many days because of there. And then I realized once I got out of surgery, my mouth was so dry. I was like, I would have paid every money in my bank account just to get a glass of water or something. But so surgeries were a lot, and it was more, I think, upfront and just in your face constantly. As long as you're in the hospital, it's just like it's right there. It's like going through chemo. You had the ups and downs of a treatment, the recovery, then you get a little bit of break. Surgery, and when I was in the hospital, it was just like 100%, 100 miles an hour, never quit. And then unfortunately, the first five big surgeries I had complications where I had other surgeries a few of the times. My hospital stays, they were like, oh, you'll be here 6 days. It turned into 15 days. So it was just realizing that, again, guidelines and everybody's different, everybody's body, and mine just was not a fan of the hospitals.
Yeah, and thanks for giving, a candid explanation for what your experience was, because I think our impulse is to reassure people that everything's going to be fine. And then when expectation and reality don't meet, things are really hard to cope with that. And you also mentioned, complications. Complications happen. They're a risk of all surgeries. They're definitely a risk in colon cancer surgeries too. So, your experience there is really helpful to arm people with the expectation that they may need if that's their path. Uh, wrapping up here, to Mark, we'll start with you.
Yeah.
For anyone who's newly diagnosed with a colon cancer, they're worried about what the future's going to hold. Any words of encouragement for them that might help them get through this tough time?
Yeah, I mean, there's a lot to unpack in what you two gentlemen were just saying. I love your driving analogy, Kyle. I'm going to take to the air. My analogy is flight. So what I
Oh
mean
yeah.
by that is oncologists like ourselves, we're like pilots. We've studied the principles of flight, lift and thrust and drag. But a patient like JJ, he just flies. And so he actually knows how it feels more than you and I do. And my practical education going through my own cancer was far more informative than any textbook I ever read. JJ, just to empathize with you, when I had half my pancreas cut out, my stomach stopped working for 5 weeks. I had a tube down my nose that whole time. And almost every day I asked my surgeon, hey, like, when is my gut going to wake up? And he was a brilliant man. He just didn't know. And and I agree with you. It's like time elasticizes, and you feel like this is going to go on forever. What I hear in your words, though, JJ, is a message of hope that I hope to amplify. And I also want to emphasize what Kyle said, which is that patients are experts in ways that he and I are not. And they're embodied experts. You know how it feels. And also, you found in other people and other patients, not necessarily an exact roadmap of how it was going to go for you, but at least some sense of how it might proceed. And also, I think hopefully an antidote to some of that loneliness. I was diagnosed with cancer as a man in my 30s, and boy, did I feel isolated. And also, as men, we tend not to talk about this. We tend not to talk about physical symptoms, and we certainly don't address adequately the mental health aspect. And it's really, really scary going through cancer. And so, again, I so appreciate you willingness to talk today. So, Kyle, my answer is one of hope. We've never been better at treating cancer than we are right now. JJ mentioned the profound issues he had with nausea and vomiting. For what it's worth, and again, flying in the face of sort of macho stereotypes, young men by and large have far more issues with nausea from chemotherapy than almost any other demographic. So, JJ, you were not alone in that. On the other hand, Kyle and I actually belong to sort of this huge national organization of oncologists called ASCO, the American Society of Clinical Oncology. When ASCO marked their 50th anniversary, JJ, they looked at what were the 5 greatest milestones in the history of oncology over the last half century. And that included things like our ability to cure testicular cancer and cure certain types of lymphoma. But on the top 5 list were anti-nausea drugs. Because for medicine, and you know this, for medicine to be effective, it also has to be tolerable. And you talked about some of the side effects that we just can't avoid, like cold sensitivity from the chemo that you've experienced. And I actually just saw someone yesterday, JJ. There was a snowstorm here in Salt Lake. I gave them the full Fox you talked about, and I felt terrible because I knew they were going to go out and they were unavoidably going to experience some of that cold sensitivity you mentioned. On the other hand, our anti-nausea drugs are getting better. And so many of my patients, I'm sorry what you've been through, JJ, but many of my patients never vomit. That's how good some of the anti-nausea medicine is getting. And then finally, we very briefly touched on this, Kyle, but I think it's important to know for your audience that not all cancer treatment involves chemotherapy. So JJ mentioned that he's receiving a form of immunotherapy, and to me, that's the next great revolution that we're living through in cancer care is immunotherapy. And the way I explain that to my patients is, what if we could train your immune system to see the cancer as if you have an infection? Because the problem with cancer is because it arises out of our own bodies, it looks to our immune systems like us. It looks like what we call self. But what we need to do is have our immune system see this as something profoundly abnormal and foreign, and to sort of harness the immune system to attack that. The best example, and I know it's a really weird example to end on, is we're recording this when President Jimmy Carter recently passed away. And he died at the age of 100, but he survived through his 90s largely because his doctors gave him immunotherapy. So it worked for a 90-year-old man to have his immune system retrained. He had melanoma, so a completely different cancer. But my point is, if someone in his 90s can have cancer and his cancer had spread to his liver and his brain, and his doctors were able to sort of train his immune system, if you will, then there is definitely hope for younger and younger patients to benefit from immunotherapy as well. I lived through this as an oncologist. When I started practicing, quote unquote, all we had was chemo. I gave immunotherapy for the first time in 2011 and watched someone's melanoma melt in front of my eyes. It was absolutely incredible. It's the closest thing to a miracle I've seen in my career. And my hope is that more and more patients will become eligible for immunotherapy. And listen, if we were recording this podcast 200 years from now, I can't imagine that we're still going to be using chemo. I think chemo is going to be seen as sort of one of these things we did in the past, like bloodletting. I think chemo is going to go away. I certainly hope it will. But for now, for some people, they still need chemotherapy to survive. And we're trying to make that both more effective, but also more tolerable.
I think that sounds amazing. The treatments we have, we're making more tolerable. The treatments that are emergent, this immunotherapy and things like that, offer a lot of hope for people. And I can speak to, most of my time spent in the laboratory where we do work on coming up with new therapies that are not chemo. And there's a lot of excitement in the laboratory. It takes a while to get into clinic, but I want to echo all those statements. I think we have a lot to be hopeful for in the future. JJ, what about from your perspective?
Yeah, I mean, I'm going to echo the same thing as hope. Like I said, in September is going to be a decade that I've been since I was introduced into this world to now, and the improvements and just the things I've seen, and especially since I've got into the more of the advocacy and the clinical trials, because a clinical trial did save my life. Like the immunotherapy I was on, I was part of a clinical trial, and it was like my Hail Mary. And again, hope, I'm like, it doesn't work for everybody, and I know it's always going to be a long shot, but I'm living proof that it does work for some people. Or I would have been gone a long time ago. But especially just the advancements, and then in advocacy groups, in the way to get information, in the way to connect to people, has changed so much even since 2015 to now. And it's continuing to evolve to where groups and people are even getting off of social media and creating their own, chat groups or their own apps to where they're not controlled by, some major corporation. It's just all focused on us as patients. And to see the advancements in that is incredible. And it's, I don't know if it'll ever be able to be like quantified how much, but just the connection that you can have, or the more avenues for somebody like me that can share my story, that it might touch somebody that I'll never know. And so I can't imagine in 10 more years how many avenues and pathways there'll be for that. And then just, again, just you're the patient and it is your life. and always put that first, because if you're not able to enjoy any part of your life, even through cancer, which, is life changing, which can, be the worst and the hardest thing that you ever went through, you got to try to enjoy parts of it. And the quality of life is everything, because if you don't have that, it ain't worth going to the chemo chair all the time, because then what are you doing it for? So I just always try to, say that and just put that in people's mind. But really, it's hope. And I can't wait to see where we are in 10 years.
Yeah, I love that sentiment. Completely echo it. I think a large part of what we're trying to accomplish here and what is an inevitability in the field is how we're all coming together in a way that we haven't been able to do in the past because we didn't have the tools we have now. So now patients, providers, and all these other groups can come together and we can, better tackle this issue of cancer together. And I think that's the way of the future. It's inevitability. And there's a lot of reasons that we can all wake up feeling hopeful for the future, just as you all mentioned. Well, thank you both for taking the time out of your busy days to join us here and, and share your excellent knowledge and expertise with the folks listening. To those who are listening, please remember to subscribe, and you can always visit crackingcancer.org for more information and to join our mission. All right, bye everyone. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.